This is Pretty in Practice, the podcast.
Opinions expressed on this podcast are solely those of our own as well as our guests and do not reflect the views and opinions of our respective employers, organizations, academic institutions, committees, other groups, or individuals. Hi everyone, welcome back to another episode of Pretty in Practice. As always, we are going to start with our Doctor's Diaries question. Okay, so this one is, what is your biggest pet peeve?
I have a lot, some a little bit more serious than others, but I'm going to say this just because it's probably not common. But what it annoys me is when I do something for someone, someone does something for me and I say thank you and they say instead of you welcome. I don't know why that annoys me so much. It's just, I just personally feel like it's kind of like get out of here, and I just want a you welcome, or at least a welcome, you know. It doesn't take
not
that
even you.
much, so it's probably, I'm probably an N of one, but yeah.
That's fair. Anybody else?
I mean, the one that comes to mind is being late in time for me.
Oh,
I
we
mean, I'm
all
slowly
know
getting over that. But
that is definitely her pet peeve. Mine personally is when people lie to me. Especially like if I give you the opportunity to tell me the truth, and you don't. That is like my biggest pet peeve, because I'm just, especially at this big age, like we're all adults. You have no reason to lie. Like, just be honest, you know. So I think lying is one of my biggest pet peeves.
This is so crazy because I know I have some. I just can't think of them right now. Like, I know stuff annoys me, but my mind is just going to think. But yeah, I mean, I don't like people lying, especially when I ask you in a way that it's obvious. I know I just need you to tell the truth. Like, I'm asking you very specific questions, and it's just like, I don't know what you're talking about. Like, that is pretty annoying.
I agree with that. Okay, so on our episode today, we are going to do something a little different. So we are going to work through a patient case. It's a case that we made up, and we wanted to highlight a topic or a disease that definitely affects the Black community at 2 times the rate of affecting those of European descent, and also point out the fact that this condition specifically is affecting Hispanics as well, and their mortality rates have increased since 2013, according to the Centers for Disease Control and Prevention. And so that condition that we're going to talk about today and work through is a stroke. And so we'll start with just some simple definitions of what a stroke is and what the 2 different types of strokes are.
Yeah, so a stroke is essentially an interruption of blood flow to the brain. And that is specifically interrupting oxygen flow to the brain, because as you know, a lot of people may or may not know, the way your oxygen gets delivered to your body is through the blood supply. So there's 2 different types of strokes. There's a ischemic stroke, and then there's the hemorrhagic stroke. So the ischemic stroke is actually due to the blood vessels becoming narrowed or actually blocked. The hemorrhagic stroke is as a result of a blood vessel actually rupturing. So that kind of sums up the 2 different types of stroke.
Yes, thank you for those definitions. So we're going to start with the case. I'm going to read the case, and I'll be taking pauses after maybe every 1 or 2 sentences to explain what this would mean to me as a medical student and then as a future doctor. Okay, so let's get into it. A 60-year-old Black man with a history of hypertension, hyperlipidemia, and diabetes presented to a comprehensive stroke center with a sudden onset of weakness of the right side. So I wanted to point out and stop here. I already mentioned strokes are more common among people of color, so that's one thing I would have to take note of. Strokes are also more common in men than women, and so our patient here is a man. Also have to, tally that up. The patient we are describing in this case has several risk factors for stroke, including his age. So according to the Centers for Disease Control and Prevention, the chance of having a stroke doubles every 10 years after the age of 55, and our patient is 60. So this is definitely something that's on the radar. He also has a history of hypertension, which is just the medical word for high blood pressure. He also has hyperlipidemia, which is the medical term for high cholesterol. And then he also has diabetes, which we refer to as like high blood sugar. And so all of those are risk factors that I would take note of when this patient was presented to me. His wife was present and denoted that he has a family history of stroke. On examination, he had right facial droop, right hemiparesis, and global aphasia. So his family history puts our patient at a greater risk of stroke. Our patient also has several signs that are consistent with stroke. So starting with the right facial droop, this is commonly known amongst like the general public. If you see someone who has like that facial droop or twisting of one side of their face, a lot of times that's like your signal that this person may be having a stroke. Then we also have, or this patient has hemiparesis, which is just paralysis of one side of the body. So in this case, it is the right side. And then he also has global aphasia. So this is when a person has impairment across all language modalities, meaning our patient in this case may be having some trouble speaking and understanding language. A CT without contrast of the head showed hypodensity in the region of the left middle cerebral artery. A CT angiography confirmed occlusion of the left middle cerebral artery. Okay, so CT stands for computed tomography, and it is one of the imaging tools used to help diagnose a stroke. It can also be used to diagnose many other diseases and many other abnormalities. Our patient CT showed a hypodense area, which means it was dark. There was a dark area on the CT scan in the area or in the region of the middle cerebral artery. So that would indicate to me as a physician, well, I'm currently a medical student, but as a physician, that there's a high chance of an ischemic stroke. And again, ischemic just means blood flow is restricted or reduced from that part of the brain. According to Johns Hopkins Medicine, a CT angiography is a type of medical test that combines a CT scan with an injection of a special dye to produce pictures of blood vessels and tissues in a part of your body. So in our patient, the CT angiography showed that there's a blocked blood vessel, and that blood vessel is the left middle cerebral artery, so we can confirm that our patient is definitely suffering from an ischemic stroke. And this is consistent with all of his right-sided symptoms because they tend to occur on the side of the body opposite to the occluded blood vessels. So if his left middle cerebral artery is being blocked, then he's going to produce signs on the right side of his body. Initial management of this patient included assessing the airway, breathing, and circulation, something that we refer to in the medical field as the ABCs. After stabilizing the patient, a blood glucose is ordered, which results in a value of 108 milligrams per deciliter. So this blood glucose is okay for a diabetic patient who took insulin shortly after dinner, according to his wife. The reason it is important to check blood glucose is because hypoglycemia, which just means low blood sugar, can oftentimes mimic symptoms of a stroke. This patient is a diabetic and he complies with his treatment plan, so therefore we're not suspicious of hypoglycemia. Additionally, his value was 108 milligrams per deciliter, which is okay. After confirming that there are no contraindications, which is important, we want to make sure before we give a patient any kind of drug, we want to make sure that that person is not at a higher risk of some kind of crazy side effect. The patient was administered Adaplase, which is a thrombolytic agent that will be used to break up the blood clot that's blocking the patient's middle cerebral artery. And endovascular thrombectomy is also being considered for this patient, in which a surgeon can remove the blood clot under image guidance. So that's what an endovascular thrombectomy means. So now I want to ask India, from a pharmacological standpoint, what are some additional things that we would need to do for this patient after starting his Adaplase and confirming that he did indeed suffer from an ischemic stroke?
Yeah, so I want to touch on the Adaplase and just say that we want to make sure that we start that early as possible. We want to really get in there and break down what we call a clot, which is something that happens, the platelets, which are normal components of your blood. And what happens is that they usually control the blood and they help form clots, as well as, just make sure that if you are having a cut or a scratch or something, they make sure that, don't bleed out or anything like that. But in a stroke situation, he has had too many platelets going on, so we want to make sure that we are getting in there, one, and busting down the clot that he has. So that's what the Adaplase is going to be. It's going to be something that we are administering intravenously. And then the second component that we need to think about for him is antiplatelet therapy, which is what I was just talking about, the platelets that circulate around in your blood. So in the hospital, we want to make sure that we do give this patient aspirin, which is something that everyone should be familiar with. Aspirin That's going to help ensure that, there's not too many platelets in the blood and it's not overclotting. And we're also going to make sure that the patient goes home with aspirin. It's usually going to be low daily doses of aspirin. For those who don't know, aspirin can contribute to internal bleeding. So we want to make sure that we're treating the patient as safely as possible, but still controlling any of the aspects for any secondary strokes or anything like that. So the patient's going to need to go home with aspirin. There are also other antiplatelets out there like clopidogrel or Plavix, if you guys have heard of that. FEM, prasugrel, those are other options that the patient can be on based on the physician's choice. But it's going to be really important to make sure that we are doing everything we can to prevent the clot from forming again. Another component of that is going to be treatment for hyperlipidemia, because that's a huge component to a stroke. So we want to make sure that we are monitoring the patient's cholesterol level, ensuring that the patient has non-pharmacological information about what they eat, so making sure that they are controlling their fat intake and all of that good stuff and knowledgeable about that. But then from a treatment stance, we are going to want to make sure that this patient is on what we call a statin. So if you guys have heard of Lipitor, which is atorvastatin, simvastatin, those are going to be things that help control just the cholesterol level overall in your blood. So this patient's going to need to go on that, and likely a high intensity statin.
Perfect, thank you, India. And then Justice, I wanted you to talk a little bit more about your experiences with stroke patients and what that recovery process looked like.
Yeah, so a lot of times after a stroke, patients have physical impairment. So some of those things could be like weakness or lack of coordination, problems walking, loss of sensation, balance deficits, problems with grasping, visual loss, and trouble speaking. So many of those things we do treat, and other of those things we have to keep in consideration. So like from this personal case, I would definitely peek more at the hemiparesis. So I would have to know that that patient is likely from that left MCA. I know that I'm likely going to walk into an eval with a patient who has right-sided weakness. And generally, an MCA stroke, you're generally going to see more weakness in the upper extremity. So I'm probably going to look at that right upper extremity a little bit more. But also I have to keep in consideration with my treatment that I'm preparing them to go home. So it kind of depends on what setting I'm in, but we're always preparing a patient to be as independent as possible and to be able to go home, because that's generally everyone's goal. But a big thing in this case was the global aphasia. So when you're treating a patient, you have to be able to communicate with them. So it's really hard to teach them when to walk if they can't understand you, and they also can't respond to you. So with that global aphasia, that would pose a big amount of a barrier to therapy. So it would be definitely harder for them, but one thing I do want to note is that this is brain damage, and though we can't fix brain damage, we can help the stroke patient have better long-term outcomes. So there's a term that we use called neuroplasticity, and that just goes to show that the brain has the ability to rewire and improve the circuits that it has after a stroke, or in general every day for everyone. But it's very important for a stroke patient because we cannot correct that brain damage, but we can help them get better. So if the patient can't walk, we can find alternatives to get them moving around better. A lot of times the base is trying to get them to transfer from a chair to a bed, because that's important, or trying to get them to stand for balance. But it kind of all depends on what level of care they're in. So they're obviously always going to start out in acute care at a hospital. And from there, based on how severe their impairments are, will determine where they go. So some patients walk out of a stroke and they're fine. They can walk out of the building. You don't even know they had a stroke. Whereas other patients, they have a super flaccid left or right arm in this case, and they can't use it at all. They can't activate the muscle. So it truly depends on their level of impairment. But a lot of times for moderate or severe cases, they generally go to what's called inpatient rehab. And that's also kind of a hospital setting where there's still nurses, there's still doctors, they're still under very strict care, but they're getting a lot of therapy. So when they send them inpatient rehab, they also have to consider if they're able to take on 3 hours of therapy a day. So they get 3 hours of therapy a day for 5 days a week in inpatient rehab. And generally, it's the bottom line is that they can handle 3 hours. So they're super. They have that global aphasia and they have severe hemiparesis, and they don't think that they'll do well. They'll send them to a lower amount of therapy because they can't stand it. So if you can't stand it, what good is it going to do for you? So inpatient rehab is really big in stroke. I personally just did a 12-week contract at an inpatient rehab hospital, and I was on the stroke and brain injury team, so I've seen a lot of those patients come directly from the hospital into inpatient rehab, and they generally only get an average of 14 days.
Do you think that's enough?
It's not enough at all. So this is high-level care, so it's expensive, I get it, but like these patients need, like, we all know that they have the best outcomes with interventions within the first couple months. And then they start to plateau after that. So like getting them the most amount of therapy in the beginning is the best and ideal. So if I could recommend all patients like that to go to inpatient rehab, that would be ideal. But obviously all of them cannot. So there are other like options for therapy that some patients go to. So I also do a little bit of practice in skilled nursing facilities. And so basically that's like a nursing home, but it has a rehab. So there's people who come there strictly just for rehab, and then they'll go home. But the level of therapy is a lot less. So patients in a skilled nursing facility get maybe 30 minutes of therapy 5 days a week. So a lot less, but if the patient can't take it, like that's a better amount of care. And if they can't go home for someone to help them transfer, because sometimes they're a Hoyer lift, like their family can't lift them to the other bed. So this is an alternative if someone can't care for you at home. So there's that too. So, and then from there, so if they do leave like a SNF or an inpatient rehab, there's always the options of home health or outpatient therapy. And generally they allow the home health is if you can't leave your home. So they're still in need of a lot of therapy. So the therapist will come to them, and generally they'll focus more on trying to make them more efficient in the home. And a lot of times, even if they do go to inpatient rehab and things, it's nice to have a home health therapist come in and practice with them in their home. Because we can set up and pretend as much as we want. My patient can tell me that their tub they think is 17 inches, but they have to step over that to get in the shower. Like that's a barrier for them to go home. Like you have to shower. So I have to think about all those things. Are there stairs to get in the house that you used to be able to do, but you can't do anymore? So a lot of those things come into play. So if they are able to leave their home and they're doing pretty well, they can go to outpatient therapy, which again is now at a lower level, so you're likely going to get 3 times a week, maybe at an hour. And so the focus is very different in a lot of those cares, and it truly depends on a patient basis, because we can have 2 stroke patients with similar hypodense areas in their brain, and they still present totally different. And there's nothing we can do about that but treat that patient for who they are and what they have going on. So what's their house like? What's their family support? There's just a lot of things you have to take in consideration because we are the ones who prepare them to go home. So like their medical care is cool. Like generally at that point, like there's not a ton left of medical care after like 2 weeks or so. Like there's some management, but like now it's physical deficits. Like so yeah, that's a lot of.
I have a question. I don't know if you know, but like at what point do occupational therapy come in and assist? Like do they have to wait until physical therapy is done, or is that done at the same time?
Yeah, it's generally simultaneously. So like when I was in the inpatient rehab, like they have 3 hours of care there. OT and PT are coming in at the same time, and we're splitting that time. So they get an hour and a half of OT and an hour and a half of PT, or sometimes 2 and 1. Or also they get speech, like if they have that global aphasia, so they'll be split at 1, 1, 1. So it very much just depends, but I would say like a lot of times when the OTs will focus on like making sure they can shower and bathe and dress and stand up to brush their teeth, or how are they going to do those type of things. And then I'll come in and make sure that they can balance and transfer and stand to do those things. Or some of these people are trying to return to their job, so like I have to prepare them to be able to walk a certain distance to even get back to their job. So that's a lot of things that take into consideration.
It is.
There, so it's not as simple as it may seem, but
and even harder on the patient.
So like they're in a traumatic position, like they're living somewhere else. And I'm coming in to force them to do therapy every single day. Like it is hard. And I know we spoke on it in another episode. Is like I get to see patients in very, very vulnerable states. So sometimes it's important that I like be vulnerable back, because they think that I'm just the most perfect human when I walk in this door, because I walked in the door just fine. Like, like you can't see my ailments right now. So
that's very interesting. I'm really happy that we decided to talk about stroke today, just so everyone is a little more aware of the risk factors, and what that treatment looked like. So if you're someone who personally has suffered from a stroke or have a family member who has suffered from a stroke, give yourself grace, give your family member grace, because it is very serious. I know that we were always taught in med school, time is brain. So it's very important to kind of know when and how to recognize a stroke. So with that, I'm going to give you guys a way to remember some of the common signs and symptoms of a stroke. In the medical field, we call it FAST, F-A-S-T. So the F stands for face. So ask a person to smile. Does one side of the face droop? So if you're sitting at a table with someone and all of a sudden, you see that their attention is elsewhere or not present at all, ask the person to smile and see if one side of their face droop. And then A stands for arms. And so ask a person to raise both arms and see if one of the arms drifts downward. That's another sign. S stands for speech. Ask a person to repeat a simple phrase, so like unlock the door. Is their speech slurred or strange? That's like another red flag. And then T stands for time. If you observe any of these signs, so any of those three signs, call 911 immediately, because again, time is brain, meaning the longer they go without oxygen to that part of their brain, the worse their outcomes will be. So please be mindful of these signs and symptoms among your family members, obviously among those who are over the age of 55, but even if you have family members who are younger than that, who suffer from some of those risk factors like high cholesterol, diabetes, or high blood pressure, always try and be aware and alert and kind of just on the lookout for things like that. So I hope you guys enjoyed today's episode. Our goal was really to make you more aware of strokes, how it presents, and then to show you how we work as an interprofessional team in the medical field. So remember, no matter where you are on your journey, always keep it pretty.
As always, thank you for joining us for the ride. Be sure to keep in touch by following us on Instagram and subscribing to our YouTube channel at Pretty in Practice. Feel free to send us a DM of any topics you want us to discuss, and you might hear them on a future Pretty in Practice episode. Keep it pretty.